We'll give folks a few moments to get logged on from the waiting room. Alrighty, I'll start my introduction so that we don't eat into our valuable time. Thank you everyone for joining us for our second to last session of today. We are welcoming Dr. Jennifer Cadigan to present on adolescent suicidality. Really excited to have this session today. We reached out to Seattle Children's and Jennifer's team to see if we could get something like this going. It is such an important topic. It was actually, we focused a lot on adolescent suicidality over the last several years. And so really happy that we are able to have a session again this year, specifically where we're going to be talking about postvention. Dr. Cadigan will be discussing prevention and intervention as well, and then highlighting some of those postvention responses to suicidal crisis. So I'm going to run through Dr. Cadigan's bio and then speak to a couple quick little housekeeping items, and then I will turn it over to her. So Dr. Jennifer Cadigan is an assistant professor in the Department of Psychiatry and Behavioral Sciences at the University of Washington and is a licensed psychologist at Seattle Children's Hospital. Her program of research focuses on adolescent and young adult health and well-being, with an emphasis on the etiology, prevention, and intervention of substance misuse and co-occurring mental health concerns. She is principal investigator of several NIH-funded grants. Her work aims to develop, test, and disseminate innovative prevention and intervention programs to reduce substance misuse and improve mental health among adolescents and young adults. Clinically, she works with adolescents presenting with depression and suicidality at Seattle Children's Hospital, in the Behavioral Health Crisis Care Clinic, and in the Mood and Anxiety Program. Welcome, Dr. Cadigan. So before I turn it over to her, a couple quick housekeeping. Please ask lots of questions, place them in the Q&A box, and let's reserve the chat box for sharing resources, introducing yourself, etc. And then this is being recorded, and we will post the recording and slides within the next week or so on our website. Final housekeeping item, there is a survey for you to complete if you need a certificate of attendance. We will pop that link in the chat. If you're going to attend our final session of the day after this, please wait until that session ends before you fill out the survey. Otherwise, if this is your last session today, you can go ahead and fill that out at the end of this session. All right, that is everything from me. Thanks so much for joining. Dr. Cadigan, take it away.
All right, thank you, Megan. Thanks for inviting me today. So hi, everybody. I'm Dr. Jennifer Cadigan. So like Megan mentioned, I am an assistant professor in psychiatry at the University of Washington. And clinically, I also see adolescent patients at Seattle Children's Hospital. And most of the patients who I see are adolescents who are in some type of suicidal crisis. And so a lot of the work that I do with them is really focused on crisis intervention, crisis management, and helping kind of get through that initial crisis. So today, if you have questions as I'm talking, feel free to put them in the Q&A, and I can kind of answer the questions as we go along. I'm also going to try to leave a chunk of time at the end for Q&A as well. So just know that we'll try to have a large kind of portion of time at the end to answer some questions as well. So all right, let me get started here. So I have, no disclosures to report. And just as a, obviously you saw the title of this presentation, we are going to be talking about suicidality. And so just knowing that, that is a topic for today. I just want to acknowledge, I know this is a sensitive topic, and at the same time, a really important topic for us to talk about. So do what you need to do to take care of yourself. And I hope you can join us today. But if this feels like this is not the time to sit in on this recording, you can view it on the website another time. So do what is best for you. Okay. And so really kind of the purpose of today, we're going to be talking about lethal means restriction and safety planning techniques, which are both evidence-based interventions for managing a suicidal crisis. We're going to talk about other brief interventions. And then we're also going to talk about postvention response, about what to do after a suicidal crisis. Okay, so just to start here, we know that suicide is really a national concern. And I'm specifically today going to be talking more about the adolescent population. So suicide is the second leading cause of death among 10 to 24-year-olds, which is just, the first time I heard this stat, it's really shocking, I think, to hear. I think we kind of hear about suicide, but I think we don't realize how prevalent it can be. So this is also when we hear about that there is a kind of youth mental health crisis, a young adult mental health crisis. Certainly part of that is this really alarming rate of suicide among adolescents and young adults. Suicide deaths have increased overall during the pandemic. So there was some data have recently shown that 1 in 5 adolescents have indicated that they have seriously considered suicide in the past year. And 1 out of 11 have reported that they have attempted suicide at least once in the past 12 months. So here I want to show some data about attempts and deaths related to suicide. So under the attempts, we see self-harm, cutting, piercing, self-harm, poisoning are all within the top 10 causes of non-fatal emergency department visits in the United States. And then you can see under the deaths column, we see information about hanging, strangulation, and firearms. And really what this tells us is that more people attempt by overdose or cutting, but more people are actually going to die by suicide by firearms, hanging, strangulation, and suffocation. And part of what we're going to be talking about later is means restriction in terms of reducing access to some of these means that somebody could use to commit suicide. And so one of the things that like I said, we're going to talk about that later in terms of means restriction. In Washington state and nationally, females have attempted suicide more frequently, and yet males die by suicide more often at a much higher rate. And so one of the things is 72% of all firearm deaths were suicide, and 51% of all suicides were by firearms. And you can see within that young adults, 18 to 24 range, 53% died by a firearm, 32% by hanging, strangulation, or suffocation. And so part of what we're going to be talking about in terms of means restriction certainly is about firearm safety, but in addition, reducing access to other potentially lethal means. Okay. So this is showing emergency department visits across the state of Washington. And what you can see here is that, oh, did I just advance? Okay. So this is emergency visits across the state of Washington. These are not necessarily suicide attempts, but these are statewide data of non-fatal, any kind of drug overdose across the state of Washington. And so I just want to point out that top line, that kind of blue line, is ages 11 to 17, right? So when we're kind of specifically talking about overdose and a adolescent population, we see that adolescent population had the highest rates of emergency department visits, really kind of consistently throughout the past 5 years. And then I also want to point out the next highest group, right, is this young adult group as well. And this is showing overdose hospitalizations, again, by age. So this is kind of statewide across the whole state of Washington. All drug and opioid overdose hospitalizations, and this is just from the past 4 years. And so what we see is that there is an increase in hospitalizations in the past couple of years for almost all ages. ages 10 through 17, which is that kind of top light blue line, there was a sharp increase during kind of the initial early stages of the pandemic. But as you can see, that line has been decreasing as we kind of get out of the pandemic. But I think more concerning is that there are increasing rates of overdose hospitalizations for all of these other age groups in the more recent years. So we're going to be talking now about suicide care treatment, intervention, and prevention. And so one of the things is that research has shown that asking about suicide does not give somebody the idea to die by suicide. And I think this is a say kind of like a myth, I guess, perhaps, that a lot of people are concerned that if they ask somebody, that's going to make somebody all of a sudden think about suicide. And there is so much research showing that that is actually not true. And I want to again repeat that. So research has shown that asking about suicide, asking, are you thinking about suicide, does not give somebody the idea to suddenly commit suicide. It does not all of a sudden increase their risk of suicide. And I think, in fact, asking that question and talking about that suicide really creates a safe, kind of comforting space for somebody to know it's okay for me to talk about this. It's okay for me to tell somebody how I'm feeling. And I think for a lot of people, it could actually feel kind of some relief that somebody's directly asked that question. And it really kind of can open the conversation. So asking that question, right? Are you thinking about suicide? Kind of a lot of people kind of get worried about, like, well, what do I do? What do I do if somebody says yes? And again, this could be for any age, right? So we're talking about adolescents today, but with any age group. And so one of the things to kind of think about how to respond to that question is, first of all, just having a safe space to have this conversation. And one of the things you can do is really kind of validate somebody's feelings by saying things like, I'm here for you, right? Tell me more about that. I hear you. I understand what you're saying, right? So really kind of fostering the space where somebody feels comfortable to talk about what's going on. The other things that you can do is, if there is a thinking about like access to mental health care, if somebody is saying, like, I think maybe I need to meet with a therapist, it's a great way for somebody else to kind of support you and thinking about how to get connected to a therapist. So that could be part of this question of, are you meeting with a therapist right now? And if you are, this would be also a great thing to talk about with them, right? Talking about that in kind of a safe, comforting way. And if not, like, that's a great follow-up question too of, have you ever thought about meeting with a therapist? And maybe I can help kind of walk you through how we could do that together. Of course, if there is an imminent danger of somebody's actually saying, yes, I'm going to kill myself, and it feels like an emergency of something that is going to happen kind of now, go to the emergency room, right? Don't leave them alone. The other thing is the 988, which is the National Suicide Prevention number, which you can call, which is also a great kind of resource for somebody if they need more support too. So again, as we're talking about suicide, I want to just reiterate that asking about suicide, directly asking this question, does not give somebody the idea that they are suddenly going to die by suicide, or it does not increase their risk. And in fact, a lot of research has shown it actually does the opposite by kind of fostering that space of, it's okay for me to talk about my feelings and somebody's asking me how I'm doing. So we're going to talk a little bit about overdose here, and then we're going to talk kind of more broadly about lethal means restriction. So specific to overdose, what happens when somebody overdoses? This is kind of what would happen at Seattle Children's. So kind of the first part would be somebody would enter the emergency department. If they needed to be medically admitted for whatever reason, so if they needed, this would be if somebody was having, for example, seizures and needed to actually be admitted to the hospital, they would then be admitted. Other people go to the emergency department and can just leave the emergency department if there's no medical reason for them to stay. Other options would be psychiatric admission after they are medically clear. So that would be an inpatient psychiatric unit. There's also intensive outpatient programs or partial hospitalization programs. So intensive outpatient programs, the acronym is IOP, which stands for Intensive Outpatient Program. And those are typically like a couple hours of treatment a day. So 4 hours of treatment a day, maybe 3 to 4 days a week. So very different, right, than kind of like a weekly therapy. This would be for somebody who needs a higher level of care. There's also what's called partial hospitalization programs. That acronym is called PHP. And again, that would just be more care, right? So partial hospitalization might be like 5 to 6 hours for 4 days a week of treatment. And then there's what the outpatient services where that's kind of what we typically think about with therapy. So that would be once a week for an hour, talking to a mental health professional. So I just want to point out there really is kind of like a range. And so when we're thinking about if anybody's, working with patients or thinking about kind of what to do with a patient, there are always higher levels of care than just once a week therapy for an hour, right? And that would, for most people, would be an IOP, an intensive outpatient program, which would be a couple hours a day. And so I want to just briefly talk about what happens at these different levels of care. On the left are different levels of care here that we really briefly talked about, and on the right are different mental health interventions. And so there's a lot happening on this slide, but a lot of the interventions are really kind of similar across the level of care, but it's really kind of how intense and the duration and frequency of that intervention. So for example, like we mentioned, for somebody who's going to an intensive outpatient program, the interventions used would be very similar to just weekly outpatient. So a lot of that would be DBT, which stands for dialectical behavior therapy. There could be family components, there could be an individual component, and those same interventions would be used for somebody who is admitted in a inpatient psych unit, but it's really just for somebody who is at that intensive outpatient level of care. They're just having more of it a week instead of just the 1 hour of weekly therapy. And then this is showing just that there's a lot of different mental health professionals within a hospital system. Mental health evaluators are at the emergency department. They are licensed therapists who are primarily working in the emergency department. There are psychiatrists, there's psychologists, there's mental health therapists, there's social workers, there's case managers, and kind of so on. I think sometimes people get confused because there's like so many people within this system, but this is really kind of a list of all the different treatment providers and clinicians who you might encounter in this setting. Okay, so we are going to talk a little bit now about intervention and prevention techniques. And so the main ones we're going to talk about today are lethal means restriction and safety planning, which is also called crisis planning. Those are both evidence-based tools, meaning that they have shown to be effective in preventing increasing kind of self-harm during escalations. And so we're going to talk a little bit more detail about both of these and what these might actually look like. And so, yeah, both of these can be used for overdose, self-harm, and suicide risk. And so I want to just point out, I know this is the overdose series, but as we're talking about lethal means reductions, I'm kind of thinking more broad, right? So we're going to talk about potentially medications that could be used for overdose, but also in general, how to reduce access to means when somebody is in a suicidal crisis. So this could be anything that they might consider using to commit suicide and how to reduce access to that. So overdose is kind of one part of a larger picture here. And so when we talk about lethal means reduction, it's literally like exactly what the name says, right? So we are reducing access to somebody having potentially lethal means. And so what this would be essentially securing items that somebody has identified that they could use to hurt themselves with. And so, for example, one of this would be like ensuring that medications are locked, removing firearms from the home, storing firearms and ammunition, this kind of triple safe storage. And so when we think about that, it's making sure that the firearm is locked and stored securely, but also that the ammunition is not loaded in the firearm. So the ammunition is stored separately in another locked lockbox. Also securing kind of other means. So this would be if somebody has talked about drowning or suffocation, about reducing access to potentially means that they could use to those types of means. Also securing other potentially dangerous items, knives and sharps, cleaning products. So I think one of the things I want to talk about with this also is there's a lot on this list. And so when we think about somebody who is talking about suicide, is talking about a plan for what they're going to do, what we want to do is thinking about, again, how can we remove access so that person doesn't have those things. And so we can't, keep people in a bubble, right? There's always going to be stuff around that, right? Potentially anything could be dangerous, right? And I've had many families make some comments like that, right? Like, well, they could potentially use anything, right? Which is true. And so a lot of the times when we're having these conversations with teenagers and with families, it's really kind of identifying what would be the things that that person has identified they could use to hurt themselves. And so we always talk with every family about removing firearms. Just like how I mentioned earlier, the firearms kind of make up the largest percentage of suicides are death by firearms. So making sure firearms are secure. But this would be an example of if somebody had said, for example, a plan that they were going to kill themselves to overdose on medication, right? So we would want to know what their plan would be. So if the plan would be to overdose on medication, we can then ensure that the medications are locked in addition to the firearm. But maybe for that person, we wouldn't necessarily need to think about knives and razors if they're not saying that they're at risk for that. And so this is very much dependent on kind of a conversation with the individual and what they're saying and what they, what also you as the clinician think would be appropriate to remove those dangerous items. And so there are many ways for how we can have these safety devices. And so, for example, at Children's, there are firearm lock boxes that we give out to family. And in those lock boxes, like literally, it's just like a toolbox with a lock. And so we can put the firearm in that. Again, the ammunition stored separately in another lockbox. That could be used for sharps. That could be used for medication. And so a lot of the times we will give families a lockbox to actually store medications. If somebody has come in on a suicide attempt that has been an overdose attempt, we will absolutely recommend to the family that those medications are locked, right? And if the person is taking medication, then we would have the caregiver administer the medication to them, right? So the caregiver would give them the pill that they need for that day, for example. Cable locks can be used kind of for larger firearms, and then there's also trigger locks as well. And so these are all things that are provided at no cost to families in terms of thinking about how can you reduce somebody's access to means. And it's interesting to have this conversation, right? So I have this conversation with adolescents all the time, and part of what I'm asking them is, I want to make sure that you're safe. What do you potentially have at home that we should consider having your parents hold on to for a little bit so you're safe? And so some people will say, knives, some people will say razors, some people will say medication. Those can be kind of some of the answers. And so one of the things I want to recommend people, if you're interested in learning more about this, is there is a free online training called CALM, excuse me, is the acronym, Counseling on Access to Lethal Means. And I linked the website here, but maybe we could, Megan, like send the website out later to people if you're interested too. And really what this is this is a free training through the Zero Suicide Initiative website. And it's really this online training on how to talk to caregivers, how to talk to people about securing firearms, securing medications, securing other potentially lethal means. It's about a 2-hour course. This is primarily designed for mental health professionals and people who work with other people who are at risk for suicide. So this is a really fantastic training if you are curious about this and want to know more about like how to have these conversations with people. Okay, so we are going to talk now about safety plans. And so what a safety plan is it's really a written document that outlines essentially a plan of how somebody is going to cope when they are in a heightened emotional state. So when somebody is in this kind of moment of distress and maybe those suicidal thoughts are really kind of increasing, what they're going to do to keep themselves safe. And so this could be strategies of how they're going to distract themselves, what they can do for comfort, who they can talk to at that time for, again, just distraction or coping. And I'm going to go through a couple of examples to show you all what this would look like. But this is really helpful in terms of thinking kind of ahead of time of when somebody is in that crisis state, when those thoughts of suicide are escalating, when that emotional state is shifting, of what are things that you can do to stay safe. I'm going to show you some examples of what this would actually look like. So there are there's a lot of names for this. So you might hear me refer to it as a safety plan. It's also, some people call it a crisis prevention plan. Sometimes people call it a crisis plan. The Stanley Brown safety plan is a specific type of safety plan that I'm going to show you as an example. There's also what's called an escalation plan. And again, that's kind of as somebody's mood is escalating, or you might hear it as a self-care plan. So a lot of names for really the same thing. And again, this is really this idea of how can somebody stay safe when they are in this escalating state of heightened emotions. These are just some examples of what it looks like if you've ever kind of like seen what some of these documents look like. But all of the safety plans, really the goal is to identify what are the triggers for that heightened emotional state, what are the triggers for some of those when those thoughts of suicide become stronger. How can we decrease access to potentially dangerous items? So again, that's that lethal means reduction. Excuse me, I was just talking about. And then what are coping strategies that that somebody could do? So I want to walk through an example of what this would look like. This is called the Stanley Brown Safety Plan. You can Google this. This is like a publicly available safety plan. This is something that I would do with a patient for somebody who's coming in and saying, this would be for somebody who actually had a suicide attempt, but for somebody who's just coming in and saying, I'm having thoughts of suicide, we would work on this together. And so I want to just, we're talking about this as, again, related to suicide, but a lot of the times how I talk about this with people too is the idea of like, when you have that kind of heightened emotion, right? When you are really angry or really sad or overwhelmed, right? Or those emotions are just getting like so big. What do you do to calm down, right? And I think that's kind of just like the basic understanding with this for all of us is, how do you calm yourself down when you are in those really distressed states? And again, for somebody who's having thoughts of suicide, knowing that those distressed states are even even more heightened, right? So what are those tools that somebody could do in those moments to help calm down? So the first part is thinking about having somebody kind of walk through and think about like, what are your warning signs that those thoughts of suicide are increasing? And some people might say like, when my parents yell at me, or when somebody says something mean to me at school. Or the other warning sign could be like another emotion of like when I'm feeling really overwhelmed, right? Like I know when I'm feeling that way, that may lead to thoughts of suicide. But this is really important to kind of walk through to get an understanding of, so if somebody has some kind of awareness of what are those warning signs that a crisis might be developing. The next part is thinking about what are internal coping strategies. And so these are things that you can do to take your mind off the thoughts of suicide. And really we think about this as like distraction, right? So during those moments where suicidal thoughts are escalating, where it feels like there's a crisis, where it feels like all I can think about is thoughts of suicide, what can I do to distract myself? And I'm going to go over some examples of this on a later slide of what that is. And the thing with this is things without contacting another person. So these are what are things that I can do to take my mind off of it. And so some people might say, read a book or watch a movie or go for a walk or, eat like a comfort food. And so again, there's only this list 3, but I would really want people to kind of generate like as many things as they can think of for what those coping strategies would be. For a lot of people, I try to be like, if you're actually doing this with a patient, like I try to be like as specific as possible. So if somebody says like, watch a TV show, I try to have them be as concrete of like, well, what TV show would we want to watch in that moment, right? And how can you have that show like ready to go? Like maybe it's in your, Netflix, like queue, or like, how can you access it quickly? Because we want it to be like in the moment. I don't even have to think about it. I can just like turn on that show as a distraction. The other thing a lot of people talk about music, right? So again, the idea of like, do you have a playlist ready to go? Where like, I don't even have to think about it in the moment. I can just have a playlist that I can pull up on my phone. And I know that that playlist is going to help me distract. The next part would be thinking about who are people or social settings that provide distraction. And so these might not be people you don't necessarily want to like talk to and tell what's going on, but rather like who's somebody you could just talk to talk about something you like. And so this would be, so sometimes people will say like, oh, my friend and I like whatever sport, or we like to talk about this movie, right? So who can you call or text to talk about something that you have in common, something that you like, that's a distraction. Maybe this is parents too, right? And then there's places where could you go? This is a little tricky, right? Because if somebody is in that suicidal crisis, like I don't necessarily want them like driving somewhere. So sometimes I think about places, somebody might say like, oh, I like to sit in my backyard or get some fresh air and just like walk outside to just like get some fresh air, something like that. The next part is people who you can actually ask for help during a crisis. And so for a lot of people, at least with teenagers, we want them to think about like, could you talk to your mom and dad about this? Could you share that you're having a hard time? And having them make a list here. And then the last part is if they have a therapist, we want them to write the therapist down. The suicide prevention line is here. That 988 number would be here. And then the last part is what we previously talked about, which is how can you make the environment safe, right? So this would be like reducing access to lethal means. What do we need to lock up? What do we need to give to your parents? And again, the idea being when somebody is in that kind of escalating crisis state, people can be really impulsive. And so how I kind of describe this with patients is like, when you are in those really, really strong emotions, I don't want you to have access to anything that you could potentially use to hurt yourself. And let's just remove all of those things so you don't even need to see them in those moments, right? And so that would be, again, making sure the medications are locked, making sure potentially the knives are locked. So when somebody is in that crisis impulsive state, they're not even looking at those objects. They're not even around. So I mentioned this kind of internal coping strategies. I want to show you a couple examples of what this might look like. So for a lot of people, sometimes they'll say like, I don't know, right? Like, what are those internal coping strategies you could use to distract when you're having thoughts of suicide? And so these are, I'm going to go through kind of two interventions that we talk about with people. The first is self-soothe. And if anybody's trained in DBT, this is a DBT skill. So again, DBT is dialectical behavior therapy. And this idea of self-soothe is really thinking about how do you engage the five senses when you're overwhelmed? So thinking about what could I do for sight that's pleasurable or soothing, right? So one example might be like, I could just watch the sunset. I could look at, my pet sitting peacefully. Sound, right? So a lot of people will talk about like their favorite song as something that's comforting. Other people will talk about like a TV show as like background noise that's comforting. And again, these are all things of like when you're feeling overwhelmed, when those thoughts of suicide are escalating, how do you start to calm yourself down? Taste. A lot of people will talk about like just eating a comfort food. And so if somebody says this to me, right, like my next question is like, what's the food? Do we have it at home, right? Because if you don't have it, we need to figure out a way how to like stop at the grocery store and make sure you have that food. Touch, put a soft blanket. Oh, typo, it should be on you. And then touch, some people will talk about like petting an animal, right, as something soothing. And then smell, what could you do? A scented lotion, potentially like lighting a candle if they're a little older and it's safe. And so this is one intervention that we use to think about what are those internal coping strategies, is to go through these self-soothe. And I just want to say to the group, I know, again, this is kind of specific to escalating emotions in a suicidal crisis, but I would encourage all of us to use this to think about like, maybe you're not necessarily having thoughts of suicide, but for all of us, when you're feeling overwhelmed, when you're feeling stressed, when you're feeling those strong emotions, right? Like, what do you do to calm down? What do you do to manage the distress? And if you have things, fantastic. And if you don't, I think this could be a great place to start for all of us, is thinking about like, what could I do with those five senses? Just when I'm feeling overwhelmed, how do I calm myself down? The other intervention that we use is called TIP. TIP is the acronym. Again, this is another DBT skill. And the idea with this is it's literally changing your body chemistry by increasing heart rate or decreasing heart rate. And so these are great skills, again, for somebody who is in a suicidal crisis where maybe your heart is beating faster, right? Or there's this kind of change in body chemistry going on. The first one is to really kind of adjust the temperature by splashing cold water on you, right? And so the idea behind this is, you could dunk your head in a bowl of water, or if some people don't want to do that, right, like take a cold shower, or literally take an ice pack or a piece of ice and just like put it on you for like 30 seconds, not to self-harm, right? So I wouldn't want it to be longer than 30 seconds. But I think a lot of people can relate to that idea of like, how do you feel when you jump into a cold shower, right? And you kind of have that shock because it's literally altering your body chemistry. And so this idea of cold water can help lower heart rate. And so again, this would be a great skill that I talk about with people all the time about what to do when you are in that kind of escalating emotions, how to calm yourself down really fast. Intense exercise is another thing that's great. And then the paced breathing, about literally kind of slowing down, practicing breathing when you are in those escalations. And then the other one is paired muscle relaxation, which is the idea of you are kind of tensing and releasing all of the muscles in your body, and noticing kind of a difference of what it feels like after you tense those muscles. So sometimes, just like as an example, you could like take your hand and make like a fist and just kind of hold it and kind of like push all your fingers together, hold that for like 10 seconds, and then you slowly release. And like for me, I feel kind of like a tingly, warm kind of sensation. But the idea would be you would do that throughout all the muscles to tense and release. I would say most people like the cold water because it's easy, and it's most people are able to kind of grab an ice pack to literally kind of adjust that body chemistry, and it lowers your heart rate. So I also want to talk about what to do after a suicidal crisis. So a lot of this that we talked about are things that you could also be doing before, but also after a suicidal crisis. Like we talked about the lethal means restriction and those safety plans. So there's a couple things I want to show you that we talk about in detail after a suicidal crisis. The first one, like we mentioned again, is how to safety-proof the home. So this would be, again, for somebody who has thoughts of suicide, maybe they went to the hospital with suicidal ideation, maybe they attempted. Again, what would happen when they come home after? And so, like we mentioned before, how to secure and lock up objects that somebody could use to hurt themselves. And again, this would be medications. So certainly if somebody had attempted suicide by overdosing on a medication, I would want family to lock up all of the medications, right? So this would be all over-the-counter medications, certainly including Tylenol and ibuprofen as well. So, excuse me, there's a list of other objects here that you could potentially consider about kind of how to keep your house safe. And I think as we're, again, kind of talking about this, we can't secure everything, but we would want to kind of focus on what would be those objects that somebody has previously talked about that they would use to hurt themselves, or they actually have used to hurt themselves, and how do we secure those objects? The other thing, this is something that we talk about too, is how to support a child. And, you know, this is child, but this is really anybody after a suicide attempt. And so one of the things that we all talk about a lot is this idea of having like structure and routine, right? So what we don't want is for somebody to come back, say they went to the hospital, they come back home, and now they're in bed sleeping for the next week, right? They don't leave the house, they stay in bed. So what we would want to think about is like how to start to implement some structure and some routine kind of back into their day. And so that might be thinking about how to have somebody start to re-engage in school, right? And so trying to get back into maybe not everything, but how to get back into some of those things that provided a sense of routine. And so using that kind of safety plan that we just talked about in terms of thinking of what are those internal coping strategies that they can do, who could they call, who could they contact in a crisis. And so what I do with that safety plan, and the one we went over was that Stanley Brown, is I will print multiple copies, and I will give a copy to, assuming, you know, the child is okay with it, give copies to parents. I will give a copy to the child. I will encourage the child to take a picture of it on their phone so they have it, because I think a lot of people like lose paper. And so a lot of the times in my office, I'll just say like, why don't you just take a picture of it so you have it? And then save that picture as like a favorite, right? So you have it. Or I'll have parents like tape the safety plan on the back of their door, right? And so the idea is all of their coping strategies are easily accessible. They have it right there. And so part of this with the safety plan is thinking about like, where are you going to put it up, right? Like, how are you going to remember to use it in those moments? So this is just an example of kind of like a worksheet that we might use with somebody in terms of having the caregiver or even the child start to identify like what are potential safety concerns and then how to then safety proof the home. And so you can see there's kind of some like big buckets here that we typically talk about with people for what that would be. And then also kind of having a conversation of what are potential barriers and solutions to safety proofing. So again, this idea, the barrier could be like if somebody has overdosed, we could think about like, again, putting medications in a lockbox, making sure that the child doesn't have medications in their room. And so what that would look like would be what we would call a home safety sweep. And so this would be essentially going into each room of the house, looking around, thinking about, is there anything that the child or whoever could use to hurt themselves. And so once you find something, you're going to remove it and lock it and store it. And so how I talk about this with teenagers is this idea of like, we're not trying to punish you. You're not in trouble. We are just removing things so you can be safe. And so a lot of the times I'll encourage the teenagers to do this together with their parents, right? This idea of like, can you just walk around your room? And if you find something that you feel like that I might be tempted to hurt myself, give it to your parents, right? You're not in trouble, but we want to remove any of those things. And so like I have had people who have found random knives in their room, right? Those are great things to give to parents. People talk about like removing blades. This would be like razors in the bathroom. Again, if they are talking about wanting to kill themselves with a knife or a blade, I'd want parents to take away those things too. And again, I think having this conversation is really this idea of, again, not shaming, but how can somebody, again, keep themselves safe and what could we remove temporarily to help keep themselves safe? So if they are in another crisis, they're not tempted to hurt themselves with something lying around. So the last thing I just want to talk about is this connection to ongoing mental health care. This is for children and adolescents. Seattle Children's has the Washington Mental Health Referral Service, which is a number anybody can call, and they will help. Again, this is for children and adolescents, but they will help connect somebody to a mental health provider. And they will ask about kind of preferences, therapist preference, what kind of mental health services that they're looking for. And there are essentially treatment navigators that answer this line that will help connect a family to a therapist. And then I just wrote hope here because this is, I think, one of the most important things I think we can do as a community, as a mental health provider, as a caregiver, as any kind of citizen of the world, right? Is this idea that to instill hope that things might be awful right now, and that does not mean they will be like this forever, right? Instilling hope that things can get better and somebody can develop more coping skills and that there can be some hope. And so I think this, again, this idea of fostering and instilling hope is really, really incredibly important as we think about working with people who are in a suicidal crisis. So I I just wanted to show these numbers here. Again, emergency crisis numbers 988, which is the suicide crisis line. You can also text that number as well. And then here is my contact info. So if you have questions or want to know about more resources, feel free to shoot me an email. My last name, Cadigan, j@uw.edu. So feel free, to follow up and send me an email if you have questions about anything we talked about today or anything we didn't talk about that you're interested. I'm happy to follow up over email if people have additional questions. So I want to leave some time for open questions and Q&A here.
All right, folks, if you have questions for Dr. Cadigan, looks like one just came through. Keep typing them out in the Q&A box. So is there a way to get those worksheets that we could utilize for our individuals?
Yes. I'm trying to think the best way. Megan, if I send you stuff, can you like send it on for the group?
Yeah. Okay. Yeah, and I can post them with this session and its recordings and slides on our website as well.
Yeah. So I can send a copy of the like Stanley Brown safety plan and the self-soothe and the tip skill. So we all have that.
Perfect. Thank you. While people are typing out some more questions, I have a couple for you. So I'm just curious, when you are trying to do a sweep of the home and removing access to lethal means, how are you determining the most likely means that someone might use? Because I would imagine that the direct ask won't encourage, maybe doesn't apply to this specific part. How do you determine that?
Yeah. So number one would be firearms. So regardless of somebody saying like, I want to shoot myself, if there is a firearm in the home, that absolutely needs to be secured. And again, that's just because the highest rate firearms lead to the most suicides are death by firearm. So firearm, absolutely. And really, like kind of I mentioned before, if somebody is hospitalized for an overdose or for cutting, we want to secure those means. And part of that is just having a conversation with somebody about asking of if they had a plan, what would they do, right? And then the idea of wanting to secure those things of what they said as well. And I just see something in the chat or the Q&A. What would you say to a teenager having thoughts, but family is culturally against professional help? Yeah. So one of the things we have at Seattle Children's is this program called Cultural Navigators, which is really a great resource. And there are people on our team who kind of help work with people from diverse groups and from different cultures in terms of how to talk about different mental health concerns with those people. So I would say number one is if you have somebody in your organization who is in a similar role like that, I think those people can be incredibly useful. Part of what the first step would be is really kind of educating on what mental health services are. I think there's often this black box of like, what is therapy? And I don't know what happens. And so one of the things I might think about to do with the family is to talk really about what is the purpose of the visit, so they know, right? What is the purpose of what we're doing? What would the session look like? So the family is aware, and the goal of what the therapy is, right? So for a lot of people, the goal would be, again, having maybe coping skills for managing that distress. And that might be kind of the language I might use, is to help so-and-so learn strategies for when they're feeling really overwhelmed about what they can do. And that's what the therapy would work on, right? So I think kind of just that initial background and buy-in of what therapy is and what the treatment is would be really important for people who might not understand that. And And I think also with teenagers, right, they are, at least in the state of Washington, the age of 13 is the age needed to consent. So somebody could get treatment without the consent of parents. And so making sure that that person does have access to the crisis hotlines, and again, that they could access therapy on their own without their parents' consent if they are over the age of 13.
So another question from my team. Do you have any suggestions or resources you recommend to help folks cope with secondary trauma, since many of our attendees are going to be people who have clients or patients that are struggling with suicidality? So what are some resources or tips for that?
Yeah, that's a great question. One of my colleagues, Jeffrey Song, I think is his last name. I can send this to you all as well. He does a lot of fantastic trainings that are really kind of trainings for providers who have had patients die by suicide. And so I think seeking out what those trainings are for professionals and how to support yourself during those times is so, so incredibly important. I can send some of those resources to you, Megan, but I would look up kind of some of those provider trainings about how to support yourself during those times. I think this is also a great thing of thinking about, like, how to, connect with colleagues and how to have that support if you are in a hospital system where you can connect with colleagues during those times to talk about this as well.
Yeah, and anything you send our way, I can get posted along with your slides and other resources. Let's see here. I think I'll just end with one last question if we don't have any other audience questions coming in. This is a common question we've been asking throughout the series. What is one action step you would like our viewers to take?
Yeah, I mean, to me, the action step is one of the slides of, like, if you are concerned about somebody, whether it's a child or a friend or anybody in your life, ask the question of, are you having thoughts of suicide? And so not being afraid, I know that's a very scary and loaded question, but not being afraid to ask that question to somebody who, if you are concerned about them, asking that question and opening that dialogue of, you're there, you love them, you are supporting them, and how you can be helpful and kind of validating and comforting to them. So asking a scary question.
Great. Thank you, Dr. Cadigan. I think that is the perfect thing to end on. We really appreciate you bringing your time and expertise to us today. And for all of our attendees, please join us at our final session of the day. It starts at 3:15 and it's on nationwide newsworthy drugs with our managing director at the Washington Poison Center. Thanks again, Dr. Cadigan, and thank you all to everyone who attended.
Thank you.